Thanks everybody. So thanks Sujina and Mental Health America of Greater Houston for doing this. This is uh, happy to be part of talking about one of my favorite subjects, value-based care, and why as a country we need to be doing this, especially in the setting of integrating behavioral health into to primary care practices, or integrating primary care into behavioral health practices. Like we'll go either way on those two things. So anyway, my name is Ken Yonda, and just a little bit of well, I mean, just a little bit of background about me to start with. As Sujina said, I founded a new consulting firm 4 years ago called Wild Blue Health Solutions, that's really trying to help primarily work in the space between providers and payers in trying to drive system change, whether or not that's integrated behavioral health, or how do we pay for the social determinants of health, how do we implement new payment models into the system. At the same time as I'm doing consulting, I'm also part of the faculty of the new University of Houston College of Medicine, which is focused on primary care and underserved populations. But before that, I spent 40 years working for big insurance companies, and a big portion of those 40 years negotiating provider agreements with companies that I work for, between Prudential to Aetna to Humana to finally Community Health Choice, which is a nonprofit health plan that's part of the Harris County Hospital District. So I've seen it from the perspective of insurance companies working in the commercial space, the Medicaid space, the Medicare space. When I'm not working on actual trying to drive change from interaction between doctors and hospitals and insurance companies, I also do a lot of policy work as well through a number of different organizations. And I'm a huge baseball fan, so if you want to talk about integrating behavioral health into Major League Baseball, we can also do that at the end as well, while you have my baseball card. It would be really helpful for me if we could just quickly go through can we do this, Sujina, just so I know where people are coming from in terms of their own introductions?
Sure, yeah, we can get started. Gregory, do you want to start us off with your introductions, please?
Well, maybe he stepped away or something.
Yeah, maybe. Eric, I see you have your camera on, so do you mind going first?
Sorry, guys, I was muted on a different location. Sorry about that. Go ahead, Eric.
Eric's still muted.
Okay, I guess I'll go. Good morning. My name is Gregory Trant. I work for HCA Healthcare in Pasadena. I'm a patient navigator for behavioral health, and we are looking at incorporating some options within our PCP clinics that we support to help drive better health care for our patients and reducing their ER time.
Thank you, Gregory. Eric, you want to go next?
Yeah, I think I've got it figured out. Good morning, Ken. Thanks for hosting this call. Eric Osland, one of the co-founders and CEOs at Evolved MD. We are an integrated care provider. We deliver services through the collaborative care model. And today we've got just over 80 individual primary care sites that have clinicians on site, fully embedded using the model. So excited to hear about what you have to say today. Thanks, Ken.
Thank you, Eric. Bridget, if you want to go next.
Good morning. My name is Regina Walker, and I don't work for any healthcare organization. I am a LCSW. I am a social worker / therapist counselor here at the Beacon, and with in the program for Bridget's Hope, and I work with women who have some health issues. I am just kind of interested. I've been following the integrated care model. I guess since y'all started, I've been on some of the Zoom calls, and just interested in what they're doing and how it works. I'm considering maybe doing some contract work or doing something later so that's kind of my interest in it. We don't do any of that here at the Beacon.
Thank you, Regina. David, you want to go next?
Sure. Good morning, everybody. Hi, Eric. Good to see you again. I am a CEO of a small technology startup company. We are focused on providing tools to streamline the intake of patients and the long-term monitoring of patients using text messaging and a large library of validated screening tools for behavioral health and social determinants of health, and anything you want, actually. We give a clinic a turnkey operation that eliminates the use of the labor force to do screening, which is such an onerous burden on most organizations. The situation that we've encountered now, which is one reason I'm on this call, is that behavioral health in the area of value-based care and value-based payments has a challenge in quantifying its effect. And if you can't quantify the effect of integrated care and justify the expense of staff and time to do it, they may be left behind. So I've been working with the Collaborative Family Healthcare Association in several of their special interest groups that are working to define measurement-based care and outcomes research for behavioral health. So I'm very interested in anything anybody has to say about measuring outcomes. Thank you.
Thank you, David. Akashi, I'm sorry if I said your name wrong. If you want to go next.
Yeah, you actually said it right. My name is Akachi, and I am with Texas Children's Hospital in Houston, Texas. Part of our value-based team. I manage our value-based care team, and just, wanting to learn more about how we can fully integrate or more integrate value-based care with providing the best care for our pediatric population. It seems like there's a lot out there for the adult population, but not that much out there for the pediatric population, and to be part of that solution to fix that.
Great. Thank
Right
so
that
much
you
for
said
your-
that, because I actually have a pediatric example coming up.
Good.
Okay, next we have Janet. If you want to go next.
Hi, I'm Janet Millman. I am Director of Quality at Outreach Community Health Centers. We're at FQHC in Milwaukee, Wisconsin. And we have, I guess I'm interested in this because we have value-based contracts with some of the care management organizations here in southeastern Wisconsin, as well as with an accountable care organization. And then also we have a large behavioral health clinic here, and we're working to integrate the two, the primary care and behavioral health.
Got it. Thank you for joining. Lorraine, you're next.
Hello, everyone. I'm Lorraine Qualley with Meraki. I'm the Quality Improvement Manager, and Meraki is across the United States, and we currently do operate some integrated care models throughout the variety of states, as well as multiple different types of value-based contracting. So again, I'm here as just to continue to learn, network, really continue to stay on point with where the industry is moving. So pretty excited to see what this meeting will bring. Thank you.
Thanks for joining the call. Patrick, you're next.
Hi, I'm Patrick Martin. I am Program Development Director at a nonprofit that facilitates a care network through Eastern Texas, working with people living with HIV. And I'm interested because we contract with a lot of clinics, and I want to see how we can add some value-based components to our contracts.
Thanks.
And I worked with Regina in a previous life.
Oh,
I was gonna say, hey, Patrick. I looked at that and I thought, I know who that is.
Good
thanks
to
for
see you,
joining the
Regina.
call.
you.
Next, we have Nina, if you want to introduce yourself. Oh, I just got your message, Nina. You're an LCSW and work in a private practice. Worked in integrated behavioral health since 2014 and enjoy helping groups get started with implementing this type of care, especially the cultural and workflow aspects needed for the team to work collaboratively. I'm looking forward to refining information about the financials and outcomes. Welcome. Then we have, sorry, I kind of lost track. Lee Chan, you're next.
Hello, hello.
Hi.
Sorry, see my camera. Hello, yeah, this is Lee Chang. I'm with Legacy Community Health. I'm an internal auditor, and I'm working closely with the Senior Director of Clinical Therapy Services. And right now, I'm just trying to gather as much information as I can so that we can hopefully find the best avenues to integrate it into our clinics.
Thank you so much for joining the call.
Thank you.
Nicholas Bryant, you're next.
Hello, I'm Dr. Nicholas Bryant. I'm an owner and psychiatrist of Flourish Mental Health in Houston, Texas. So we do medication and therapy. It's a group practice. We treat all ages and basically working on transitioning from just mental health care to collaborative care, working more with primary care offices and launching that more on the private practice side of things.
Thank you so much for joining. And then we have Nicholas Autopilot.
Oh, that's me as well.
That's you as well. Ronald O'Donnell. I'm sorry if I said your last name wrong.
That was perfect, and Ron is fine. I'm a clinical professor and clinical psychologist with Arizona State University in the Doctor of Behavioral Health program, and interested in incorporating this work into my courses and consulting work. Thank you.
Thanks for joining. And I think that's everybody. Did I miss anyone? I think we're good. Ken, floor is all yours.
All right. Well, I want to make this very interactive. I have, about 30-40 minutes worth of slides. But please stop me as we go along the way. But I do want to make sure that we have quite a bit of time at the end for discussion about these things. So really, what I think I was charged with talking about today is really value-based care from the financial standpoint, from the standpoint of how to think about how insurance companies think about it. As a recovering health insurance executive myself, after 40 years, I tend to see things through that lens, as you might expect. And so we'll talk a little bit about the way insurance companies think about value-based care, how it works from their standpoint, and where's the good middle space for providers and payers to work together on these things, both in terms of sort of the mechanical components, but also what are some of the competencies that you guys need, and what might be various paths forward for you guys as we go forward. I like to always start with why are we doing this? And I always start with why, and the why, of course, for me and pretty much everything that I do is sort of what I refer to the triple aim plus equity kind of thing. The triple aim, where we want to make sure that consumers and patients and care teams are working together to actually improve health outcomes for both individuals and populations. And secondly, to do that in a way that improves the experience and the efficiency of care. And then third, to align financial incentives more appropriately so that we contain the cost of healthcare going forward. And increasingly, as I've gotten more and more involved, both at Community Health Choice, which was primarily Medicaid, uninsured people, low-income folks, other work that I'm doing now in the consulting space, as well as here at University of Houston College of Medicine, really trying to see how we can use any of these programs to decrease disparities and improve health equity. So that's sort of the why we do this stuff to start with. The model that I always think about how value-based payment models should work from an insurance company standpoint is the model that's been around for about the last 15 years from the healthcare payment learning and action network. And hopefully most of you have seen this before, which is, typically the way people get paid for services is simply pay for volume or pay for individual services. You bill CPT codes and you get paid for it with no real link to quality or value. As you move into increasing value-based payment models, you still have that fee-for-service component of it, but really right now, these sort of A and Bs are sort of gone, and most of the contracts out there have some incentives for improving outcomes, and we'll talk a little bit about more what we mean by rewards for performance. Then moving forward on from that, there might be some looking at total cost of care for patients, not just services that you provide, and looking at the overall health outcome of patients and having some more gain sharing arrangements around quality and patient experience. And then finally, more population-based payments, which really gets into either capitated type programs or bundled payments or those things that we'll talk about. So this is kind of the basic framework that we think about. And again, please, raise your hand. I'll try to watch for hands raised if you can do it electronically, or come on camera, unmute yourself as any of this doesn't make sense. But assuming that everybody's sort of seen this before or has the basic idea here. So if you think about this specifically in relation to integrated behavioral healthcare services, you sort of think about, okay, if I'm in category 1 fee for service, I've got a basic payment for medical encounters that would also include telemedicine for behavioral health standard E&M codes. Increasingly now in most all states, you can also be paid for mental health codes that include coordinated care model, or the HBAI model, which is health behavior type codes, which I hope you got to have covered all this already in earlier sessions, and I don't have to really explain those again. But that's sort of what it looks like. If you then think about any kind of bonus dollars, any pay for performance or pay for quality dollars, they usually don't exist in category 1. In category 2, you have those same fee for service codes, but you then have annual payments, maybe for improved quality, some utilization measures, possible bonuses for potentially preventable emergency room visits, potentially preventable admissions, potentially preventable readmissions, those kinds of things, and possibly even some kind of consumer satisfaction based on CAP scores or something, but generally not in this category 2. I would say, at least here in Texas, and I think this is true fairly nationally, if you're in the Medicare or Medicaid side of the world, especially with any private payer, you're probably here right now. There are lots of these kind of programs that basically pay fee schedules, but then have some kind of quarterly or annual report card that the insurance companies will get to you and tell you, sort of how you're doing on some of their quality metrics and things. And you may or may not be doing very much with that. As you move farther down the path, though, you're getting much more likely to have these additional value-based payments on top of the fee-for-service payments that we've talked about before. Plus, you may be getting a monthly per capita or flat dollar payment for care management. As you're bringing more care managers into and have a larger care team, you may be able to get from insurance companies some care management payment on top of your fee for service and bonus type payment. You might be or likely to get some kind of gain sharing. So if you think about it, an insurance company says we expect average cost to be $500 a month per patient. And if your patients that are paneled to you are only costing $450, then we'll share some of that $50 savings with you in a gain sharing type arrangement. Sometimes these arrangements will actually have both gain sharing. So if you do better than the targeted per member per month medical cost, you get some of the savings. On the other hand, if it goes over that target, you may have to pay back to the insurance company part of the overage. So that becomes, we're starting now to talk about really much more risky kinds of arrangements from a provider standpoint, but potentially a bigger share of the gain if you're willing to share some of the downside loss potential. And then finally, when you get to category 4 or population-based payments, here we're talking about if you're looking at a primary care situation that does integrated behavioral health, very likely you're looking at a risk-adjusted per member per month capitation. So rather than paying for each office visit, each service that's provided, you're given a flat dollar amount. Here, we're going to give you $50 per member per month for every member, and you are responsible for all the services that member needs in a primary care setting. The trick here, of course, is to be very clear about what services are included in the capitation. If there's any carve-outs from the capitation that you can bill fee-for-service on top of. Often, as an example, at least here in Texas, immunizations might be added on top of the capitation because the price for the vaccines can fluctuate quite a bit. In this category 4, you're talking, more at risk for both quality and utilization members. You might be at risk for potentially preventable visits to the emergency room or admissions. Get some bonus or at-risk dollars for consumer satisfaction. Still, it may be included in your capitation up here or a separate per capita amount for care management services, and some significant gain sharing or gain and loss sharing. So that's generally the components of what a value-based contract looks like from the insurer's standpoint. Let me stop for just a second just for any clarifying questions anybody has. Okay, everybody's busily eating lunch here and absorbing all this fascinating insurance-y kind of stuff, right? Oh, I will say, if you do if you're in category 4 and you're taking a significant amount of the risk, this would be very large groups. I know there are a couple of very large groups here. This is when you'd have to have many thousands of lives in order to take a full risk capitated deal like this. Even then, you'll still want to have stop loss insurance, which says that any particular consumer, any patient, member from the health plan standpoint that have claims over $50,000 or something like that, that you would have essentially be buying insurance for those people, either from the carrier who often provides that stop loss and value-based contracts, or from another stop loss carrier.
And we have a question from Nina. She's asking, what other examples of services billed separately and not included in the monthly prepayment? Would behavioral health ever be a part of that?
On the behavioral health side, it generally sort of routine counseling and those things would be included in the capitation. There may be certain services, higher intensity, less frequently provided, that would be excluded from the capitation. I'm thinking of it more in the substance use area and things. So like intensive daycare type programs and substance use disorders, maybe separated out or not. It really sort of depends on the insurance company in terms of how they want to do that. Did that answer the question?
Yes, thank you.
So Gina, can you keep looking? I can't really watch the chat as well. So if there's other interesting
I'll
things,
I'll keep an eye out for the chat.
keep for questions there. I have my slides over here on this screen and you guys, the camera over here, and I can see if you raise your hand, then I'll do that. Okay. So if you go back to here, we're talking about, okay, what are these things that they're measuring? What kinds of things, he mentions HEDIS, PPEs, all this kind of stuff. What are we talking about there? So just here's an example of the kinds of things. And again, this is for children and adolescents, but you would also have for adults, same kind of thing. You're going to have measures that the insurance companies are going to want you to work on. So for example, you might have a measure for appropriate treatment of children with upper respiratory infections, and that you're not providing antibiotics unnecessarily to them, or are you doing all the well child exams that you're supposed to be doing? These funny little numbers here or letters behind here, those are actually the code for the various HEDIS measures. There's 93 or 95 or so HEDIS measures, and they're all have these little codes like this, to where you can go to the NCQA website or the HEDIS website and actually look them up. There are some of these measures that you might find that the source is not HEDIS or is not NCQA, that might, for example, low birth weight babies, that you might get a bonus for is a CDC measure as opposed to a HEDIS measure. But these are things that are routinely calculated, where there's a pretty good formula for how do you calculate these kind of quality metrics. I have a little note here that says at risk versus bonus. So when you're talking to insurance companies, you want to make sure that you understand what they're at risk for, where they might get money clawed back by the state of Texas or whatever state Medicaid program, or clawed back by the federal government in Medicare, or clawed back by employers. Employers generally don't have clawback type provisions, but they might have. So at risk means potentially losing money, as opposed to bonus dollars, which they get extra money from the ultimate payer of these services. So I just, again, have samples here. This is for Texas, because Texas Medicaid plans actually have at risk for these measures, where they get bonuses for other things. So there's this whole idea of these HEDIS measures. Again, if you're looking at an adult population, the two most common HEDIS measures that you might have incentives for are going to be maintenance of high blood pressure, at a certain target level, maintenance of hemoglobin A1Cs for diabetic patients. Those kinds of things are usually up here in the kind of primary care and preventive care type thing. Potential preventable events are the things that save the insurance company's money. Okay, insurance companies, I can say this as one who worked for them for 40 years, are always in the business of trying to keep people from going to the emergency room unnecessarily, and going to their primary care physician and said that saves them money. So you want to look at potentially preventable emergency room visits. The same way, well-managed patients on an outpatient basis then don't get admitted to the hospital, and there's money to be saved. And I would also say on both emergency room visits and admissions, there's a patient experience that's better. Much better to go to your regular doctor than wait for hours in the emergency room or get admitted to the hospital. Being admitted to the hospital is not a fun experience for patients either. On the behavioral health side of things, you might have bonus potential for screening for depression, for follow-up for kids with ADHD, antipsychotics, not using them when not appropriate, those kinds of things. And increasingly, after you get past these sort of quality metrics or outcome kind of metrics, growing number of value-based plans are starting to look at these patient satisfaction scores that usually come from CAP surveys around rating of the doctor or getting to care quickly, those kinds of measures. So those are the kinds of things that will drive an opportunity for you to get more funds than just a simple fee-for-service type program. Let me again just stop and take a quick sip of coffee and see if there's questions about that.
I actually missed a question from Kara. It looks like in category 2A, there's a statement on foundational payments for infrastructure and operations, something I have seen missing in action and reality. Is this happening by payers in Texas?
No. Originally, when Medicare first started moving down the value-based path, they actually, within the Medicare program, had some payments where you could here, if you do implement electronic medical records, if you do start tracking certain kinds of things, we'll pay you extra money simply for doing those things. And that was really during the time of the advent of electronic health records, but everyone has pretty much moved past that at this point. So it's still on the chart, but not much out there. All right, we'll keep rolling it. One of the things, in addition to the HCP land things, one of the that we use a whole lot is the Institute for Advancing Health Value. It used to be called the Accountable Care Learning Collaborative, but the model that we tend to use at Wild Blue and is used in lots of other places too, is this idea of if you're going to move to value-based care, you need to think about sort of 4 big buckets. And the first bucket is governance, in terms of how are you going to manage your organization in terms of organizational leadership and internal roles and responsibilities? How do you engage stakeholders? Those kind of things. I think in this ECHO session, there's been some other people that more or less have talked about that bucket. So I was not going to spend a lot of time on that bucket today. The bucket that I am spending time on is what you have to do organizationally around financial models and in particular around negotiating fair agreements with MCOs. There's also a whole series of things if you're moving into value-based care around the actual care delivery, which again, the Institute for Advancing Health Values has a lot of information about these things. I'm not covering that today, except incidentally from time to time, but a third big bucket. And then the fourth big bucket that we always are thinking about is what does it mean from a IT, from a systems, what do you need to have in place as it relates to operating in a value-based care world. And I'll touch on this one a little bit as it relates to financing, but just wanted to mention that to you guys. So the way I tend to think about this stuff is, you have certain competencies, right? And certain things you need to worry about. And so from a financial standpoint, as I move into value-based care, okay, what kind of investment am I going to have to make? And just moving into getting some bonus payments for quality measures really doesn't take much of a financial investment on your part. As you move into taking more risk for care that goes beyond your own clinic walls, then you're likely going to need to invest in additional staff and potentially IT upgrades and even more as you move farther down this path. In terms of return on investment, potentially moving to category 2 is pretty much easy money. Oh, I get a bonus check every once in a while. Sometimes I don't even know why I got a bonus check, but I got a bonus check. So not a lot of worry there. As you move farther down the path and taking more and more risk, but potentially more and more reward, the ROI could be significantly better. And certainly when you move into population-based payments, capitation, bundled payment type programs, percentage of premium type deals, then potentially a much higher ROI, but also riskier. I think the idea of financial risk is pretty much the same. One of the things to think about, though, is if you as an organization are getting organizational dollars and you have 20 doctors in your practice, how are you starting to share that additional money that you're getting out of value-based contracts with those individual physicians? It may not be much at the start of value-based contracts, but best to start thinking about it. But as you move forward, you ought to have, if you think, I think, tend to think about it this way: you might get from the insurance company, or you're tracking overall sort of a clinic scorecard or a tax ID level scorecard, but you want to be looking at individual physicians that make up that and can help drive changes or different care teams, and make sure that you have a program that sort of says, here's how we're sharing the potential benefit of these value-based deals with care teams and physicians, and eventually moving it to being a significant portion of the compensation plan. Talking just a little bit more about negotiations with insurance companies. But the reality is those first few value-based contracts where you're just getting some bonus dollars, it's probably a take it or leave it deal from the insurance company. Here's the contract provision. They have a standard program that you participate in, and it's either happens automatically with your existing fee-for-service type contract that you might have with a carrier, and it just kind of happens, not much negotiation. As you move into more significant risk sharing, gain sharing arrangements, then you'll absolutely want to have some negotiations about that. And I just, it's not just a financial deal. You need to make sure that you're thinking about the clinical implications of these and bringing in clinicians into those negotiations. And frankly, if you're moving into a real population-based payment models, capitations, bundle payments, percent of premium, then you either need to hire somebody, if you're a large enough practice to where you can do this, with some actuarial understanding and experience, or you need to find consultants that can help you do those negotiations. And then in all of these, you need to be building the capabilities for data and reporting. In the first category, you may get data reports from the carrier, but you should also at the same time be thinking about your own registries and start to think about care gaps. But as you move forward from a financial standpoint, you'll have more and more people involved in the data and reporting aspects of it. Once more, I'm going to stop, take a breath, and see if there's questions about this.
Hey, Ken, can you hear me? This is Eric Oswald.
Yes.
I was busy typing this, so I figured I would just ask it since you gave us a chance. So, we've seen a lot of our customers begin to go down the value track, and most of them are either large health systems, like fully integrated health systems, that have negotiated, call it value-based agreements, or potentially primary care on their own has gone out and negotiated their value-based cares. And it's been difficult to get the systems or primary care to carve out some of that value for behavioral health. And they'll tell you that, hey, it's hard to point to the savings you're giving us because it's usually coming downstream and it's coming in the physical health realm, obviously ED visits, better outcomes, those types of things. And so do the payers want us to focus on getting a piece of that primary care integration pie, or do they want us to come directly to them and try to carve something out in addition?
I would say most carriers are going to want it to be integrated into primary care. It's happening the fastest in the Medicare space right now, where the advanced primary care groups that have integrated behavioral health services are kind of the hot new thing. And so, though a lot of them are using collaborative care models, but that's being part of that is probably a better approach. There's actually, for many years, from an insurance company standpoint, all of the behavioral health stuff was like carved out to a separate company. Here in Magellan, you take all of that, or, you know, still United Healthcare has Optum Behavioral Health and those kind of things. But more and more of the carriers are thinking more and more that they have to integrate behavioral health with physical health services. So the model for doing that is either in advanced primary care or in a clinically integrated network that would include primary care and a fair number of specialists. And behavioral health could be included in that clinically integrated network that's taking, say, a full professional. So some organizations are taking full professional fee capitation, right? If you can imagine, okay, we're going to put the facilities over here in some kind of risk sharing arrangement, but all professional services, boom, a clinically integrated network. But that clinically integrated network is expected to have behavioral health services as part of those professional services. Now, within that clinically integrated group, how you allocate the, you know, sort of the distribution of who gets what piece of it is an individual thing. I wouldn't say there's lots of standards around that from the insurance company standpoint. Is that, it's probably not helpful, but that's kind of truthful from an insurance company standpoint, I think.
Yeah, and I think that's consistent with what we're seeing. And I guess as a follow-up, you know, trying to squeeze ourselves into that conversation. Have you seen a model where behavioral health is getting X amount of the upside? Have you seen any of these that have worked? Because I mean, essentially these groups, right? They're operating in a very low margin profile, and they're trying to get their hands on every bit of revenue they can, and so trying to peel off a piece for behavioral health has been the challenge, right?
Yeah.
So have you seen anything that works?
No, but I'm not to say that it couldn't work. What I think the reality is, we're just not there yet, okay, with the model. So we had this model for many years of all the behavioral health stuff is kind of over here by itself, and here's all this physical health stuff over here, and the two worlds, you know, barely touched each other. And now we sort of swung the pendulum, and I think rightfully so, into no, this has to be integrated. You can't think about it separately. And so just, you know, that first crashing of behavioral health into the physical health pool, we haven't now started saying, okay, we got that, so now we can start figuring out how to do sort of sub portions of that. I mean, I compare that to, say, for example, some cardiology stuff or some orthopedic stuff, where you start sort of saying, okay, here we can sort of take these things out because they're more episodic. And so what we're starting to see within these value-based agreements is sort of pulling out, you know, some of the more, I think, episodes of care is actually exactly what they call them. Okay, so that kind of, but it's hard to do a lot of the behavioral health stuff, because is this, you know, a chronic condition that continues to be worked on and needing to be managed? That's a different kind of thing right now. All that said, I mean, there are starting to be some other chronic disease management cases sort of coming out. So we may see, much like in diabetes now, there's certain, like, okay, this portion of diabetes should be expected to be handled in a primary care office. This is part of the primary care expectation, even though it may have a little bit of endocrinology consult in it. But at some point, there's a certain piece of this that moves over, and we're going to take, you know, kind of this patient and put them over here into this separate pool of sort of really sophisticated endocrinology needs. I haven't seen that yet in behavioral health, though, but that would be kind of the model.
Thank you, Ken.
Anything else on this one? Okay, so let me go to the sort of, you know, Ken's 7 keys for working with payers on this stuff, and then we'll have a little bit time for discussing. So the first thing that I would say, and I say this mostly to the payers more so than the providers, is that you got to find payers that have made the leap away from who's got the best deal from somebody else. There are still lots of people that work for insurance companies in provider contract who think that their job is to screw the doctors and get the best, or the hospitals or the health system, and get the best deal possible so that it makes more money for the insurance companies. That is a dying breed in insurance companies, but I will not tell you that they have all died yet. But more and more of the insurance companies are realizing that the best way to maximize their own sort of performance gain, now that more and more of the people that pay the insurance companies, being the federal government, the state governments, large employers for self-funded insurance companies, they want to see improved outcomes. They want to improve customer satisfaction. The insurance companies have figured out that churn, that is members who come and go and are out of the system, actually are bad for customer experience scores, bad for HEDIS measures, and bad financially. And so they want to try to hang on to people longer. So in addition to making money, they want these other things going on. They realize that stability of their network, sharing gains with providers, having happy providers who stay in their network and don't leave the network and cause network disruption are all positive things. And so find the folks who are willing to collaborate. What's really somewhat surprising to me is, people like United Healthcare and Centene here in Texas, they operate as Superior Health Plan, are really pretty far down this path and sort of realizing that it's not just about this year's earnings as they go forward. And so look for the right payer partners to start with. And then you have to learn how to speak health plan, right? You have to be able to talk PMPM, HEDIS, CAP scores, HRAs. In this case, HRAs are health risk assessments, not health reimbursement arrangements, but health risk assessments, and just a gazillion other insurance company acronyms, right? Yeah, and you need to understand how health plans that are focusing on Medicaid populations operate. Here again in Texas, you need to understand the difference between STAR, which is pregnant women and kids, and STAR Plus, which is the disabled population in Medicaid, in terms of what the metrics are, what the bonus amounts or capabilities are. Again, in Medicare, there's going to be, if you're in traditional Medicare, there is the official, Medicare alternate payment model programs that there's no negotiations really with, sort of take it or leave it. In the Medicare Advantage space, which is now over half of the population on Medicare is in a Medicare Advantage plan. Here in Texas, it's about 60%. So increasingly, some of the fastest moving value-based payment models are in Medicare Advantage. And then I would say sort of the laggard of the different sectors in value-based payment models is actually in the commercial segment. For large self-funded employers, they're just really kind of still figuring this out. But that's a little bit different from those people who are buying individual policies under the ACA. So those individual policies under the ACA are starting to look a lot more like Medicaid managed care or Medicare Advantage. You also need to understand when health plans are talking about population-based payments, what does a capitation mean? What's included in the capitation, what's not included in the capitation? If you're doing a bundled payment or an episode of care type payment, what is the time frame, as well as what's included in that? And you've got to understand where the insurance companies are coming from risk adjustment. Increasingly, there's risk adjustments to the amount of premium revenue the insurance companies get, which can be then passed down into any kind of value-based payment model. So you may have heard a lot about some of the concerns in the Medicare Advantage program because it feels like insurance companies are primarily doing value-based deals with doctors in order to try to drive their risk scores up higher so they get more premium rather than using it to actually manage costs and improve outcomes. But you got to understand those risk adjustment formulas and why the insurance companies are going to be asking you about making sure that you have comorbidities documented, multiple ICD-10 codes, those kinds of things to help on the risk adjustment on the revenue side for them, rather than just on the pure HEDIS score. I think I mentioned this before. When you're talking about measures from the insurance company standpoint, are they at risk for these, or they have a potential to lose money, or is this just bonus potential for them? And then while you'll be learning about in care in your own care teams and those kinds of things and value-based models, understand how the insurance companies think about care gaps and care management programs. Again, largely to improve HEDIS scores as well as reduce potentially preventable admissions and readmissions. Third key thing is data, right? Make sure that you're keeping your own data, that you have not just EHRs, but you've developed registries of who are the list of my patients with certain kinds of chronic conditions that I should be calling back to actually make sure are in place in order to close those care gaps. You should make sure that you're getting all the reports from the payers and how that compares to your own data. One of the things that we find a lot of physician groups struggle with is simply panel reports. And this is in the primary care space, but it's like the insurance company will say, here's the 1,000 patients of ours that are in your panel that you're expected to keep up with. And you look at that list and there's 200 of that 1,000 that you've never heard of, you've never seen, you don't have them at all. Well, those are people that you either need to reach out to and find out if they have other primary care physicians or other relationships out there and get them off of your panel, because their results are going to be stuck with you if you don't reconcile the panel reports appropriately. You should, if you're early on in the value-based care journey, you should practice when all you have is potential upside in terms of what kinds of skills and competencies you need to have. The fifth key thing is don't try to do too many one-off deals, because you don't want to have as a group saying, oh, I got to go do this for United Healthcare, and I got to go do this for Centene, and I got to do this for Community Health Choice here in Houston. Oh, and there's this other provider-sponsored plan that I've got to do something else for. While instead, what are the common elements of programs, and try to keep those so that you can have your entire team, doctors, nurses, everybody in the care team working sort of toward the same goals, the same incentives, no matter which insurance company is ultimately paying for the bill. If you're having problems with that, if you're like a one or two a small clinic kind of situation, you really ought to think about working with what we refer to as aggregators. These are companies that sort of sit between physician groups and payers that they will take more of the risk themselves and perhaps pass down to you just sort of activities that they want you to do that will help them achieve the results, and they will then share those with you. I know we have a couple of people from Arizona on the call, as well as here in Texas. There's one that's working in there's only very few working in the Medicaid space. Equality Health is one of those few in the Medicaid space. In the Medicare space, there's really a whole bunch of them. Care Allies, which is part of Cigna, or is it Aetna? I think it's Cigna. There's Alliday, there's Caravan, there's different ones that operate in that aggregator space. What I do a lot with primary care physician groups, and I tell primary care physician groups don't be afraid of capitation for your own services, because largely within pretty big groups, most of your costs are fixed in a practice in terms of salaries and rent and those kind of things. But if you're starting to negotiate population-based payments that are beyond the services that you provide yourself, and now you're relying on friends and other colleagues, professionals to help manage those services, got to be a lot more careful with those kinds of deals. And the last thing that I think is really important to push back on the insurance companies on, because they're pushing back on Medicare and Medicaid for these things, is understand that when you're talking about quality metrics, if you're at only 60% of your diabetics will manage, and their target is 75%, you should negotiate to get bonus dollars for moving from 60 to 65 to 70. So you should try to get quality bonus payments for improvements. And if you are already at 75 or 80%, you should get bonus dollars for maintaining that. You shouldn't be expected to get too high of targets. And this is something that might be a little bit harder for some of the carriers and in certain kinds of deals, but you really need to, for fairness for everybody, you need to think about two different components of quality. Am I improving? Am I moving toward the standard? And then if I'm at the standard, am I maintaining it? So
there's a question in the chat from Akashi. She's asking that we run into the issue of wrong patients in our panels, and yes, it does impact the results. Have you had success with getting the insurance companies to remove the error data based on some sort of criteria, for example, adult patients in a pediatric population?
Actually, it's in the insurance company's interest to have people in the right buckets, because the reality is, just this example, if you have adults in a pediatric population, you can't reasonably expect the pediatricians to see those patients, to have them in to do what they need to do from a preventive care standpoint or management of chronic conditions. So insurance companies should absolutely work with you on that. Now, part of the problem is that, at least with some of the carriers, they're not very good at it. They don't really haven't, we send that to member services, and member services changes the primary care physician for that person, or they try to contact them, or they default them someplace. So it's not very elegant right now, but the insurance companies are not doing a good job of checking it themselves, so you have to. So with that, I did make it with 30 minutes left for discussion and questions, and we'd really love to hear from your perspectives on this. The one that I sort of accidentally skipped over, but I did want to say, if you're in a group that's primarily behavioral health providers right now, so here in Houston, the Harris Center is starting to incorporate more and more primary care physicians and moving that direction, as opposed to primary care adding collaborative care to their portfolio or other combined practices. The model is still pretty much the same, but you may want to figure out how to get more primary care, because the insurance companies are much more familiar with value-based contracts built around expanded primary care than they are expanded behavioral health, if that makes sense. Surely there's other questions. Well, while you're thinking about other questions, I also wanted to mention, as you're moving in the direction of sort of understanding where the insurance companies are coming from, and as I mentioned, you should be thinking about population-based payments, about capitations, about episodes of care type payment models. Generally, you should know that the amount that insurance companies get in terms of premium dollars, increases with age. Okay, so how much dollars the insurance company has to deal with 8-year-old children is a lot less than they have for dealing with a 68-year-old senior. So just realize that how much money is actually there in the premium dollars that can be allocated toward primary care, integrated behavioral health services. Those things is just less based on utilization and the total premium dollars that they're getting. And so
Ken Nicholas, Dr. Bryant has raised a hand.
Sure.
Questions?
Yeah, sorry, this might be a little outside of the scope of this talk. It's much more fee for service, but one of the difficulties we've run into with launching collaborative care with primary care clinics is that the codes are based on, you have to file that under the primary care doctors. And so obviously as a psychiatrist, approaching some of these primary care clinics, they don't want you billing under them. But then the insurance companies will deny payment, saying, no, you're a psychiatrist, you can't bill for collaborative care. I guess any thoughts or ways that would
well,
be helpful?
there are collaborative care codes, but there's also still traditional mental health counseling codes that you should be able to bill for actual when you have a referral for actual counseling. What you can't do is, as a psychiatrist, you can't bill for the collaborative care, which is really more around the care coordination and management that the primary care physician is doing, but it shouldn't stop you from still billing for the
yeah, no, so we're definitely billing for that. But so the difficult part, though, of course, is that primary care doctors having well-trained care managers, right, is difficult to find. So we're basically training our own care managers and approaching primary care clinics, trying to launch it with them. But yeah, we're in this difficult part where we can't code the collaborative care codes for the care manager's time. And that's supposed to be done in the primary care clinic.
Right. Yeah. Well, that's hopefully is just a transitional thing, and that will get better, and you won't be spending extra time doing those kinds of things that you're not supposed to, that theoretically somebody else is doing the care management, care coordination piece of that. But a sophisticated primary care physician ought to also be thinking about, okay, I may need to be using some of that money that I'm getting for the collaborative care code and sharing it on a monthly retainer basis or something with the psychiatrist to because there is some more value that you're helping to create for him. But that would be not a billable thing for from a specific patient standpoint, but more of a if you will, you acting as a consultant to the primary care group for helping them implement the program.
Right. Yeah, and I guess the problem is the majority of the primary care clinics, they're not quite so familiar themselves, so they don't they're not even willing to bill it themselves, right? So I guess it would have to be a little bit larger primary care clinic where they have the resources to do that and the knowledge. But we've had a hard time, I guess, because it's newer. There's not a lot of primary care clinics doing that.
Yeah. I don't know of any of the insurance companies that are actually doing that right now, but it is possible that the primary care doctor, because the insurance companies want primary care doctors to do collaborative care. I mean, it's like, and it's not just because it's a better, clinical outcome. It's like, because we think this will save us money, right? So they may be willing to provide some upfront kind of seed money to certain primary care groups in order to implement collaborative care. So I would encourage any primary care physician that you're working with to at least ask the insurance company if they would pay some some kind of implementation fee, if you will, to help the practice do that outside of direct patient care.
Okay, I didn't realize that was an option. So thank you.
Well, the insurance company has to pay for that out of their own administrative expenses. It's not considered a medical expense, and so they, might be a little bit hesitant. But some of them, have done that. Now it would probably have to be a primary care practice that was really important to the to the company in terms of the insurance company in terms of how many patients were in their panel already. But certainly in my days at Community Health Choice, well, this was before collaborative care was allowed to be paid for in that case spaces. So we didn't do it for that, but we did it for some particular groups for some other things where we thought it was really important for them to expand their capacity and capabilities for primary care groups. So.
Okay, makes sense.
Again, if I could chime in.
Sure.
I didn't get a chance to introduce myself earlier. I'm Dan Crow, I'm internal medicine physician with about 40 years of clinical experience. And I work with Ken at Wild Blue Health Solutions and doing a lot of this value-based work. And we live in an age of more data transparency, and especially in regards to the reimbursement from payers. And I think when you're coming to the table to have these negotiations with the insurers, we still have not achieved parity. And I think knowing what your data is, and we recently had a chance to look at some payment data, and we saw, subspecialists were getting 10 times more than primary care doctors were, and primary care doctors were getting 10 times more than the behavioral health folks were. So knowing what that data is like when you're going in for negotiations, and then really trying to strive for, as you move from the early categories to 3 and 4, that there's better reimbursement for the provision of behavioral health in the integrated fashion. So I just wanted to make that comment.
Other questions, comments, suggestions for the group? Well, if not, then I guess we'll give you a little bit of time back, but certainly if you have other questions, just because of, Dan and and other people at Wild Blue's long history of doing these kind of things, we also have worked with lots of different insurers. Very happy to, help any of you that want help in this space. And I don't mean as a consulting contract. We're just like two old guys that are trying to change the world. Now, if it's too many hours, we do get paid, but for a phone call here and there, we're always happy to jump on the phone for 15, 30 minutes and sort of say, okay, here's people to talk to at United Healthcare about this or different kinds of organizations, we're always happy to help make connections and also provide just kind of light, if you will, ideas on these things, as well as provide additional resources. I would encourage you all, if you haven't already, to visit both the HCP LAN website as well as the Institute for Advancing Health. I forget Advancing Health Value. Both of these organizations, there's free material there under the Institute for Advancing Health Value. There are some additional resources that are only available for members that sign up for that stuff, but good information out there for you in terms of negotiating with health plans and moving toward value-based care.
And I'd mention too, regarding the Institute for Advancing Health Value, they have a great podcast called The Race to Value, and Eric Weaver runs that, and got a lot of good subject matter discussed there.
All right.
All right. Well, thank you, Ken, for your time. If there aren't any questions, thank you all for joining us today for this call. Hope to see you all next month, and we'll send you a follow-up email with more information and survey link. Please feel free to fill those out. It really helps us to know how we're doing and how we can improve. And after you do that, we'll also send you the slides as well as the certificate of attendance, which you can also use as the CEU. So thank you all so much, and have a great day. Bye.